slide. So I will be talking on this anatomy relevant to us neurosurgeons. So it's not an anatomy for the ENT surgeons, but what we should know as a neurosurgeon doing endonasal approaches. Mostly in my practice, I get the ENT team to do the approach for skull-base operation, either a standard pituitary or standard endonasal operation, or even for extended endonasal operation where you have to do extensive resections and extensive reconstruction. But the anatomy we need to know is fairly straightforward. What we need to know is that inside the nasal cavity, we have the midline nasal septum, which is constituted of a cartilaginous part in the anterior aspect of the nasal septum. And in the posterior part, you have the perpendicular pit of ethmoid, which is bony. And also, the other bones you come across, they are the vomer, and in the midline, the floor, the crust of the maxilla and the palatine bone. And then that is the medial aspect. And it is so an easy landmark once you go into the nasal cavity. Those who ENT surgeons, they are familiar with this anatomy because they do these operations in and out throughout the day for their functional nasal work. But for us, for skull-base approach, we also should need to know the relevant anatomy along this region. But the lateral aspect is more busy. You have more structures. It's very eventful, the lateral aspect. You have all the turbinates. Essentially, you have the floor of the nasal cavity here. If you approach it through the nose, then go along the floor, you go to the nasopharynx. And then you have the first turbinate. First structure you'll encounter, because it comes more anteriorly, is the inferior turbinate. And then slightly more posterior will be the middle turbinate, which is cut here to show the hidden structures behind the middle turbinate. And you have the superior turbinate. And these two turbinates, the superior turbinate and the middle turbinate, will lead you towards your sphenoid sinus. Because sphenoid sinus is, for us, is the, once we are into the sphenoid sinus, because that's where we normally come into our operative part. That's why that the anatomy within the sphenoid sinus is what we are all familiar with. But to get into the sphenoid sinus, you need to know the anatomy, what the ENT surgeons normally use. So this anatomy is quite busy on the lateral wall. I'll come to it with some cadaver dissection. So this is the left side of the nostril. So sometimes it can be disorienting if you are seeing just the inside, because what you have to do is to look at the structures. On in the medial aspect, you have a structure without any features. Unless you have like a nasal spur or a deviated nasal system, mostly it is a uniformly characterless septum. But on the lateral side, you have the turbinates. So you know that you are in the left nasal cavity. So you have the inferior turbinate here, where then more anteriorly you have the middle turbinate. And if you then go more forward into the nasal cavity and then displace the middle turbinate a bit more medially to expose the structures behind it, you can see the hiatus for the maxillary sinus, and you can see the ethmoidal bulla as well. But normally for our intranasal procedures, we go medial to the middle turbinate. So we don't really have to go laterally to it. Unless you, in many procedures, when you have an extensive recession of the turbinates for a wider exposure, then you will be dealing with these structures. And what are the bony structures that's contained within the turbinates? You have the concha, the inferior nasal concha, and the middle concha. So these are all thin, spongy bone attached to the skull base. And we don't need to learn the intricate anatomy of it, because we often try to push it to one side or lateralize it or to resect it to get access to the sphenoid sinus. So I'll show you the anatomy which is relevant to our corridor. So it's important to balance it. The endoscope, which is a crucial instrument in these procedures. You can see that once we go into the nasal cavity, this is the left side of the nostril. I'm pushing the inferior turbinate. It's probably the ENT's colleague. So as the first thing you go there towards the floor of the nasal cavity into the corner. So clear up the corner. That is an excellent landmark for you to see the anterior wall of the sphenoid sinus. Your intention is to see the ostium of the sphenoid. So once you know the ostium, you don't have to have any worry at all. You know, in the past old days, we used to get intraoperative X-rays for these sort of procedures. Nowadays, it's very rare to get intraoperative X-rays. Of course, we use navigation as a standard for most of these procedures, but it is not needed once you know where the landmarks are. So about 1.5 to 2 centimeter above the coronal arch, you will encounter. And it's customary for the ENT surgeons, you use some patties soaked with adrenaline to decongest the turbinate, because they are all vascular structures. It's the less congestion you have, the better your exposure is. And so what is the anatomy here? So here you have just pushed the middle turbinate to one side with your instrument. You're seeing the front wall of the sphenoid sinus. You can just about to see the coronal arch here, and you can presume that behind these structures, this is the superior turbinate, which, and also something you can see a supreme concha, or supreme turbinate. And behind it's hidden the sphenoid ostium, and sometimes this is called the sentinel of the sphenoid ostium. So in order to see it, you often will have to lateralize these structures or to remove it gently. Once you remove it, you'll encounter the sphenoid ostium. This is on the left side. The featureless, the nasal septum is here, and you have displaced the structures to laterally to see it. So that anatomy is constant. Unless patients had a significant nasal surgery in the past, this anatomy is always there, and so there's no need to worry about the anatomy if you are attempting it on your own, but it's good to have an ENT support till you get some more exposure. So this is an intraoperative view of the middle turbinate, and also this is on the right side. You can see the nasal septum here, the middle turbinate here, and this is the coana. And this is the location where you have to be careful. In many procedures, even if you're not planning to do a big reconstruction with a septal flap, it's my practice to keep this area intact, because this is where you have this branch of the spinopalatal artery supplying the nasal mucosa, septal mucosa. So beyond this, superior to this artery, you have the sphenoid sinus. So whenever you open up the sphenoid sinus, this is kept intact in both sides. This is what we call the rescue flap. And here again, the sphenoid ostium is well demarcated. So I'll show you the actual anatomy. So just follow the middle turbinate and displace it laterally. You see the superior turbinate coming in, then you directly go into the sphenoid sinus. So once you see the sphenoid sinus, it's important to make sure that you make it a bit wider. So because later on, before you enter it, if you cause that swelling and bleeding, sometimes you can again miss it. So first thing I do is to try and open up a bit more. So that you can see it more clearly. Then you can use any instrument, even a debrider, to debride this structure projecting in to obscure your view. And this is this on the right side, especially the superior corner, is where we keep our endoscope to park. So once we start the skull base operation, you need a place for the endoscope to park. So that's why you need to get some clearance on this corner. That is a standard practice. So here, this is the part I said, lower part of the sphenoid recess, where you have the anterior wall of sphenoid sinus. You need to displace it rather than cutting the mucosa here. The sphenopalatine artery is there. So I'm just going to, and once you see the sphenoid recess, you can, in the midline, you know that the crust of the wormer is there. On the other side, you have the sphenoid ostium as well. Here, you can see the crust of the wormer and the mucus of the sphenoid sinus. So this is how we see it normally. You have to get the anterior wall of the sphenoid sinus resected to get into the sphenoid sinus. Again, the ENT surgeons are often very, very fond of this instrument called circular punch, which is used to expand the sphenoid opening bilaterally. Then what you need to do is to connect the two sides. So what is happening here? This is the right side, the septum is here, and this is the left side. This is the lateral wall. Here you don't see this ostium, but you see a structure protruding through it. So these are some variation you have to expect. This is a polyp, which can be easily resected with a debrider to get a good view into the sphenoid sinus. So this is the expansion you're seeing. So you get a good view. So you have two openings. All you need to do is to connect these two structures in the midline. So in many cases where you do a larger opening, often you may have to resect the turbinate. This inferior turbinate on the right side, pushing it laterally. This is coana here. So this is the middle turbinate. This is blocking your view. And it is not an unusual thing to resect the turbinate in many cases. This is the technique to do it. So you don't have to cut it at the root of the middle turbinate. Once you cut it, you just need to push it down, all the way down, then gently peel it away and then cut it sharply, but not onto the wall, because you can then damage the vascular pedicle. So here it's cut and then it's gently pulled out. So that is all there is in terms of inferior turbinate. Here you can see the middle turbinate, and sometimes it can be used as a pre-mucosal graft. But in these days, when you have a bigger repair, if we don't use it, we use the nasal septal flap. So this bullae can be safely resected without any worry. And often we use a debrider. You can use a Kerrison punch, which is preference for many surgeons. I'll pass through the next stage. So again, expanding the lower part. I mentioned about making sure that the lower part is kept intact. So this is the inside the sphenoid sinus. So all you have is the median septum here. So this is again expanded bilaterally. So what is happening here? Once you expanded the ostium, you have to go to the other side. So I'm just opening the midline septum to see the middle of the sphenoid vomer, and then you go onto the other side as well, then connect it together. So here it's on the left side now. So I just opening up that. So this is a posterior aspect of the nasal septum. So all you need to do is to remove this part, and then you have a confluent opening on the sphenoid sinus. Then I go onto the right side again, and then cut this part of the nasal septum. So this is the middle, the vomer. The keel of the vomer is being taken out by a strong forceps, and which is the easy thing to do, and that gives you the complete orientation to the anterior sphenoid sinus. So once that is taken off, what you have left is the middle septum, which you can resect as much as you need to. Here, this is an instrument, it's called a backbiter. See this, we are on the left side, we're just resecting the lower part of the nasal septum, so that once you put the endoscope in more closer to your operative field, you don't have anything blocking the view from the other side. So this is the instrument which is used to resect it off. So this is from again on the right side, same instrument is being used to expand your opening. I'll just quickly go through So coming to the anatomy of the nasal flap, which is nasoseptal flap, it is supplied by the branch of the sphenopalatine artery which comes through the pedicle, which we mentioned in the previous slide about the rescue flap. The incision for the nasoseptal flap start from below the choana, just on the arch of the choana. You can come all the way down and then can carry it forward towards the floor of the nasal cavity, and in the upper part you go above the pedicle in line with the middle turbinate resection line, and you have to make sure that you don't go very superiorly more in the posterior part, because that's where the olfactory mucosa is there. But as you come forward, you can go up towards the skull base and get a wider flap. And this is a versatile flap, and it contains a strong vascular pedicle of the sphenopalatine artery which supplies the septum. This is a subperichondrial and subperiosteal flap, which is a very robust flap and is very versatile. And this is what it's like. You have the pedicle coming here, and you can, in the back, you don't go up to avoid damage to the olfactory mucosa here, and in the front you can go all the way up to the skull base depending on what you need. You can tailor it as you wish, and even you can cross onto the floor and onto the lateral wall to make it even more wider. So how do we do this? So once the incision is made, you can do it with a knife or with a monopolar fine cautery. Then you dissect it off from the nasal cartilage and the nasal bone. So this is a subperichondrial, subperiosteal lifting of the septum. So you need to detach the lower wall, lower aspect to and detether it, and then also from the upper part you just dissect it off. Then once you dissect it off from the wall, you can store it in the choana so that you can keep it safe from your instruments and activities, so that you don't damage the pedicle there. So the pedicle will be right here. You detach it all the way down, push it all the way down. So then you can have a free access to your nasal cavity. Which side you do it, it depends on which is your preference. If you are using a right-handed person, you may want to do it on the left side, because all your drills and other instruments are often going through the left nasal cavity. So then you have the bony and the cartilage part of the nasal septum here. And it is easy to place as well. So when you place it back, you just rotate it over the anterior wall of the sphenoid sinus and then place it over the defect. This was like an invasive pituitary tumor with invasion into the cavernous sinus, which was resected with an exposed carotid artery inside the cavernous sinus. So even though there was no leak, this was used to repair just because the carotid was exposed. So, but then to get the flap to completely cover it, you have to detether it at the bottom so that you can pull it back. So now it is coming back to completely cover the your defect. There was an inlay Duragen graft as well. And then once you do it, you have to make sure that there's no twisting. So we used to mark on the surface with the methylene blue to identify the surface. Then you place it all around. And then we often, before putting some glue, we tend to cover it with some Surgicel as well. So this is the relevant anatomy for the neurosurgeons, and it is the more you do, you get familiarized with it. There's nothing worrying about it because we deal with complex anatomy in the head all the time. So for neurosurgeon, this anatomy is sufficient. Thanks, Prof. Goel. Thank you very much.